Oden French, my 32-year-old, beautifully healthy pregnant friend who passed away in childbirth after the hospital induced her labor with a drug that was not FDA approved for that type of use.
So I go down to the room that I'd left my daughter in the night before, and my son-in-law was there, and he was crying and hysterical. There's no bed in the room. It's just a big old empty room, and there was blood on the floor, and I said, and one of her earrings. And I said, "Where's Tasha?" And he said, "She's gone."
Never was a care, love was ever flowing, and it's feeling to share, and I can feel this for sure. And I've been here before.
The U.S. has a very severe maternal mortality problem. We spend more money on health care than any other country in the world, and yet have more women dying from pregnancy-related complications than any other developed nation. African American women and women of color are the most vulnerable and more likely to suffer complications or die during pregnancy and pregnancy-related complications than white women in our country. And this has got to end. If we are to eliminate preventable maternal deaths in our country, we must understand why they are happening. The recent news about Texas's maternal mortality rates being much lower than previously reported, which was that African American women died 10 times as much as white women in Texas, is a perfect example of why we need to develop standardized processes for reviewing and reporting maternal deaths across all states. The bills we're urging you to support today, H.R. 1318 and Senate Bill 1112, will help to do just that. In addition to understanding why, we must also learn from groups that have been successful in addressing maternal care quality issues. The U.S. is ranked worst among developed nations, and we can learn from countries with lower maternal mortality rates than ours. Today, you will be hearing from representatives from France and the UK, as well as the US. But before I introduce speakers today, I would like to welcome to the podium Anna Breen. Anna is here on behalf of Representative Jamie Herrera-Butler, who is the original sponsor of the Preventing Maternal Deaths Act, H.R. 1318, to provide an update on the status of the bill and what Representative Herrera-Butler is doing to push the legislation forward. Anna.
Hi everyone, thank you for coming. I don't think I really need to introduce the topic anymore because you did such a great job. But H.R. 1318, Preventing Maternal Deaths Act, is probably the top priority right now for my boss. And basically it would authorize $7 million for CDC to assist states in either establishing or strengthening their maternal mortality review committees, which we believe are incredibly well set up to help us try and understand what's going on. I thought I would just give a brief update on how the bill is doing. We have over 110 co-sponsors at this point, and it's very bipartisan. We're working with Chairman Burgess's team. I believe one of his staffers is here right now, which is great. And my boss is having really encouraging conversations with leadership. To be honest, we don't really hear anything negative about this bill. It's mostly been an awareness issue when people realize that our country is going actually in the wrong direction when it comes to maternal mortality. It's truly shocking. And I think Texas is a perfect example of why we need better data. So we would love for your bosses to consider supporting this bill. And I'm sure the organizers have my contact information, so if you have any more specific questions, I'd be happy to get back to you. And we have a really great group of co-sponsors who will be working to get this on the floor. So thanks for being here.
Thank you, Anna. And now I am honored to introduce our distinguished group of speakers. Anne Lorette, the co-founder of a French patient advocacy group, Timio, and others, will be sharing her personal birth story and how her organization has helped to end the use of a drug called Cytotec for labor induction in France. Jenny Josephs, a British-trained midwife and the founder and executive director of Common Sense Childbirth and the JJ Way, unfortunately will not be able to attend in person, but has sent a video of her words. She has personally been invited by the Vatican to speak at a new annual gathering of stakeholders called Humanity 2.0. Jenny will also be speaking in her words about the UK-based midwifery model and how it's making childbirth safer for women, and her pregnancy care center in Florida, and how the UK has successfully reduced maternal mortality rates across the nation. Dr. Christine Morton, chair of the Lamaze Institute for Safe and Healthy Births, will speak about what California has done to address maternal mortality and the role of childbirth education in supporting women through pregnancy and preparing them for unexpected outcomes. Shauna Cox, Associate Director for Science at the CDC's Division of Reproductive Health, will speak about maternal mortality review committees and the role of data in improving maternal care. And finally, Dr. Michael Liu, Senior Associate Dean at the Milken Institute, School of Public Health at George Washington University, and former Director of the Maternal and Child Health Bureau at HHS, will discuss the factors contributing to our country's high maternal mortality rate and how we need to approach the issue. After the presentation, we will have 15 minutes of Q&A. Claudia Booker, an amazing certified professional midwife and owner of Birthing Hands Midwife and Birth Services in DC, will answer questions on behalf of Jenny Josephs during the Q&A. The presenters will also stay in the room for about 30 minutes after today's event has concluded if you have any additional questions.
Hello, my name is Anne Loirette. I am from France. I'm very happy and very grateful to Madi and to the Tatia Oden French Foundation for allowing me to be here and to attend this meeting. It's an honor for me. I will talk to you about the association Timeo et les Autres and about our fight against the use of Cytotec for labor induction in France. Personally, I had my childbirth induced with Cytotec in 2007, and the contractions caused by Cytotec were so strong that the heartbeat of my baby started to fall alarmingly because he was lacking of oxygen. I was given a tocolytic drug in order to relax my uterus, and I had an emergency C-section. And just after that, I had a serious hemorrhage, which required another emergency intervention. If I had given birth in another hospital, I would certainly have received the standard drug for labor induction, a vaginal insert containing the molecule dinoprostone. With this drug, in case of excessive contractions, you can remove the insert and you will be able to stop the effects of the drug because the duration of action of its molecule, dinoprostone, is very short. It's very quickly eliminated from the body. On the opposite, Cytotec is a pill. You cut in 4 and you give orally or vaginally. Once given, you can't remove it, and even if you could, it wouldn't help because the duration of action of its molecule, misoprostol, is too long. It's not suitable for labor induction. And why isn't it suitable? Just because it was not designed for labor induction, but for stomach ulcers. Its use in obstetrics is a misuse. Using cytotech to induce labor is like driving a car with no brakes under the pretext that it's 100 times cheaper than a standard car. When I mentioned this disadvantage of cytotech in a meeting, an OBGYN answered to me that in case of excessive contractions with cytotech misoprostol, you can give a tocolytic drug to relax the uterus. You won't be surprised if I tell you that it doesn't work. For me, it's like driving a car with no brakes and in case of emergency, using the handbrake. 3 years after me, in 2010, in the same hospital, Aurélie gave birth under cytotech 2, and the contractions were so strong that her uterus ruptured, and as a result, her son Timeo is severely disabled. When I met Aurélie in 2011, we decided with our 2 husbands to found an association and to fight against cytotech, not specifically the drug, but its use in labor induction. In 2008, the French National Authority had issued a recommendation that states that misoprostol should not be used for labor induction apart from clinical trials. And the reason was that safety hadn't been sufficiently evaluated. When we created the association, some French hospitals didn't meet this recommendation, and we had to denounce them. Our model was the Tatia Oden French Foundation. Discovering Tatia's story on the internet was a big shock for us, but the website gave us a hint of what we had to do in France. So we took example on Maddie. We created a website where women could find information. We launched a petition, and we started to gather testimonies. And with these testimonies, we alerted the French Drug Agency in 2013. Surprisingly, the French Drug Agency immediately issued an alert about the risks of inducing labor with cytotech. The warning was widely spread in the media, so the OBGYN understood that inducing labor with cytotech would represent an important medico-legal risk. And the rate of cytotech inductions in France decreased to a rate of 2 to 5%. But the French Drug Agency has no power to ban nor to prosecute. So our second step was to write to the Health Ministry and to ask for an official ban of cytotech for labor induction. The ministry answered us a very nice letter, but never took action regarding cytotech. And as the cytotech inductions were mainly concentrated in the Paris region, we tried to involve the regional health agency, but this agency, instead of banning cytotech from maternity wards, just sent a questionnaire to the hospitals in order to know if they used cytotech for labor induction and asking them to report side effects. So imagine the police asking people, do you drive a no-brakes car? Have you ever had any accident with your no-brakes car? Have you ever killed a person with it? No? Okay. As might be expected, the hospitals didn't report all side effects. We know at least one case of maternal death which hadn't been reported by the hospital. Finally, in 2014, Aurélie pursued a lawsuit against the hospital where she was induced. The judgment was given in 2016. The hospital was sentenced to financially compensate Timeo. They appealed the decision of the court, but just after that, the pharmaceutical firm Pfizer decided to withdraw cytotech from the French market. So it could sound like a happy ending story, but in 2014, a new drug, a vaginal insert, like the standard drug, but with misoprostol instead of dinoprostone, was approved in all Europe for labor induction, despite some frightening results in the clinical trials. This drug is called Misodel. Formerly, the firm had applied for marketing authorization of Misodel in the USA, but Misodel was not approved by FDA because compared to the standard drug, non-inferiority could not be demonstrated. When they applied in Europe, they doubled the dose of misoprostol contained in the drug, which explains the terrific rate of uterine hyperactivity. Fortunately for us in France, this drug won't be used by the French hospitals because the French health authority refused its reimbursement by social insurance due to a negative benefit-risk profile. But more recently, another new drug containing misoprostol called Angusta was approved for labor induction in the Nordic countries and in France. And the firm announces its intention to apply for marketing authorization in the USA too. So I won't be able to conclude with a happy ending story, but rather with a call for vigilance. I am very grateful to Mehdi for initiating this call many years ago and for allowing me to be part of it. If the goal today is to determine how we can reduce maternal mortality, one of the ways will be to keep in mind that labor induction is a risky intervention that requires the greatest caution and appropriate drugs. And I think we need our health authorities to understand that misoprostol is not and will never be an appropriate molecule for labor induction. Thank you.
Good afternoon. My name is Jenny Joseph. I'm a British trained midwife. I've been in the United States since 1989, and I want to share a little bit about what I've been doing and why I think it's relevant given what we're talking about today. I absolutely believe we can transform perinatal and maternal health care in the United States. So let me share a little bit about what I do. I'm out of Orlando, Florida. I landed there in '89 and I haven't been anywhere else, but I set up a practice soon thereafter because I was surprised and shocked that the American women do not use midwives for birth. Most of the rest of the world, midwifery is the normal way to have care and to have support during your pregnancy, childbirth, and postpartum. So after much angst and trying to figure it all out, I started a birth center. Currently I have a birth center. I have an easy access women's health clinic, which is really an outreach clinic for women who choose to have their baby in the hospital but want midwifery care, or they want that supportive care during pregnancy and postpartum. And then I also use a model of care which I've named the JJ Way, which is a midwifery model of care, making sure that the woman and her family are centered in the pregnancy, that they get to make decisions, that they get information and support. And the other piece, of course, is that it's culturally congruent care, that the care is relevant to the woman, who she is, where she's from, how she needs to hear information, how she needs to be supported. We're a non-profit organization, and we've made it our work to reduce and in fact eliminate the disparities that are rampant in this United States. If you're aware, you already may know about the 2010 and 2020 goals, the Healthy People goals, which are national goals, which are set every decade to help us on a public health trajectory to know where we're trying to go. So since 2010, we've been talking about the elimination of health disparities. Currently, the 2020 goals are in play, and we've gone even further. We've stepped up a little bit. We're now talking about health equity as well as elimination of disparities. So these are lofty goals. In Florida, where I live, our 2020 objectives are here on this screen, are to show our relationship as Florida to the rest of the United States and those objectives. You see the measures: adequate prenatal care, preterm birth, low birth weight, infant mortality. We're striving to do better. We're trying to reach these goals. What's important to note, though, is that each year we don't really make a whole lot of progress. We're worsening in some aspects, and definitely the disparity has stayed vast. It has been wide. There's a marked disparity, especially between African American and the rest of the populations, but particularly against white women. So this is the graph of preterm and low birth weight in Orange County, which is where I'm operating my clinics. And you can see right here, these are old stats, but this was the first year we did a study, and we looked at the stats compared to our county. For example, black women, 21% black women having a preterm birth, 15% Hispanic women having a preterm birth. That very same year, a study that we ran of 100 of our women who were of the same demographic, the same issues, we had no African American, no Hispanic, and a 4.7% white prematurity rate. The work is really simple. What we're doing is we're providing access. Number one, no one is ever turned away. There is no barrier. We will help troubleshoot. We will triage you right there at the center to find out what we can do to help you get to the right place that you need to go. We build connections. We want you to bond to your baby. We want you to bond to your partner, your family. We want to encourage bonding to our staff so that we can then connect you to the right place, the right agency, the right hospital, the right provider, the perinatology team, whomever. Once you feel you can trust us, the knowledge that we share with you is going to be assimilated, is going to be accepted, is going to be acted on, and hence the empowerment. Those are the 4 basic steps of the JJ way. Our goal is to get this word out. We're sharing with not only our patients and their families, but our community. We need people to know that pregnancy can be made safer. There are people who are supporting this work. There's a TED Talk, which I really encourage you to listen to. It talks about how racism is one of the main factors for these outcomes and the problems that we experience. The institutionalized racism has our women in such dire straits. I have a documentary. It's on YouTube. It's free of charge. You can watch it, 45 minutes, but it explains from the perspective of the women. The women speak in this video. It's very important that we hear from the women. We should listen to what women have to say, particularly Black women. And then we share our reports. Our most recent report is the maternal justice report that shows models that work, gives pointers, toolkits, and ways to help women through these pregnancies so that they can have a healthier outcome. The United Kingdom, which is where I'm from and which informs my work and which has led me to put this model in place in Orlando, Florida, they have been following maternal mortality trends, have been investigating and trying to understand for a long time, since the 50s. You see how these reports have also improved and increased in their scope, but also in the naming and in the sharing of the information, the transparency. So from the original confidential inquiries into maternal deaths in England and Wales, it went on to now being called Saving Lives, Improving Mothers' Care. Here's where we see the clarity about what's getting done. The lessons learned were part of the report in the 2010 timeframe. The next one, though, comes into a different level, surveillance of maternal deaths as well as lessons learned, each time improving on getting the data and doing something with it. What I love about this work, Embrace is the organization in the United Kingdom that's using this method to share and learn about maternal deaths. Simple reporting is simple nomenclature. The women who died 2011 to 2013, it couldn't be clearer. That's the name of that report. And then, of course, we look at the fact that you have accessible websites. You have absolute clarity about what the work is about, what it's named, who can read it. For example, full reports, lay summaries, infographics, slide presentations. All of these things are part of the website and they're easily accessible by anybody. One of the ways that we can change these outrageous and egregious statistics is simply by getting the information front and center so everybody can see it, not just as professionals, not just our agencies, our organizations, but every woman. I believe that if every woman gets the information she needs, she can be empowered. And I believe that we in turn who want to help those women have perfect and healthy babies, great outcomes, and stay safe. If every one of us worked from that same place, if we all had access, connections, knowledge, and empowerment, we could solve this problem. I absolutely believe we need more maternal mortality reviews. I believe it should be a national imperative. Every state should be reporting. We need to change this. Clearly, it's a matter of life and death. Thank you.
Good afternoon. I'm honored to speak before you today, and I also want to thank Maddie Oden for putting this together and for her tireless efforts to improve maternal health and awareness of the issues facing our mothers and families today. I am here today as a representative of Lamaze International, the trusted leader in ensuring that all parents make confident and informed decisions that result in safe and healthy births. Lamaze teaches the 6 healthy birth practices that promote evidence-based care and gives parents tools to become better advocates for themselves and their babies. I'm a medical sociologist by training, and for the past 20 years, I've worked alongside many birth professionals who are committed to improving maternal health in California and the U.S. You will hear personal stories, you've heard some, and statistics that underscore the deep tragedy of maternal death.
I can tell you many such stories from serving on the California Maternal Mortality Review Board and from my research with women who've survived a severe complication, and from the death of my 38-year-old cousin last year, who left behind a confused and grieving family and her 4-year-old and 6-month-old sons. Maternal mortality is a personal and social tragedy I know from my family's experience. It is a sentinel health event, which is why California invested early on in learning why women died and what could prevent more deaths. It is an indicator of social and economic values, particularly in countries where women and their labors are not fully recognized as essential and critical to society. The women who die are like canaries in the coal mine. They are the ones who are more vulnerable or perhaps more unlucky, but their deaths are a sign to us all that there is something wrong with our system. Changing the system requires a political commitment that women's lives are worth saving. So why are maternal deaths increasing? It's hard to answer that question in a resource-rich country like ours, and there is no simple answer in our soundbite society. But our experience in California shows that there were many points of failure and many points along the system, and there are opportunities to improve and that change is possible. What we measure reflects what we value. My goal today and the goal of the panel is to articulate the value of women and their right to safe, healthy, respectful care during pregnancy, childbirth, and postpartum. Bad maternity systems happen to good people, to poor and rich, to white and black. Bad maternity systems hinder doctors and nurses in providing optimal care to everyone. Government action can help. If we don't have the data, we can't act. The U.S. has not released a national maternal mortality rate in over 10 years. We're not accurately counting maternal deaths, and we have only the crudest measures to count how many women have severe complications in childbirth. And we are certainly not capturing the whole scope of women's experiences with birth and postpartum care. In 2007, my colleagues at the California Maternal Quality Care Collaborative shared this slide, this data, with maternity leaders across the state to create a coalition of the willing. The California Department of Health acted quickly and used federal Title V MCH block grant funds to create the first ever statewide review of maternal deaths and support initiatives to use that data to act. And I will say that California paralleled the U.S. for many years because there's 500,000 women giving birth every year in our state. It's bigger than Canada, and it was really interesting and important that it was the first state ever to do, the first time they ever did a statewide review. But what our in-depth review of maternal deaths showed was that there were opportunities to improve at all levels: healthcare systems, maternity provider training, and patient knowledge and understanding. We recruited experts to translate those findings into action in the form of maternal safety toolkits, which provide specific guidance and recommendations for hospitals and doctors, nurses, and midwives to address preventable causes of death and complications from things like hemorrhage, preeclampsia or severe hypertension, venous thromboembolism or blood clots, and cardiovascular disease. These tools are publicly available and have been downloaded tens of thousands of times across the U.S. and in more than 80 countries. California also implemented the hemorrhage and preeclampsia toolkits in over 200 of its 250 hospitals and is working to reduce elective deliveries and cesarean surgeries. These efforts have made a difference. California has demonstrated the political will and the strength of public-private partnerships to address the needs, rights of pregnant women and their families to have safe and healthy births, and yet there is still more to do. We know that for every woman who dies, another 10 nearly die, and another 50 to 100 suffer a severe complication that impacts their transition to motherhood, and we are not counting or capturing those experiences as well as we could. The reporting over the last year from ProPublica and NPR have brought these heartbreaking and frustrating stories to us all, and we owe these organizations a huge debt for the resources they invested in telling these stories and identifying maternal deaths. If news organizations can do this, so can governments and researchers. These stories and my research with women who nearly die in childbirth reveal major gaps in information, policy, and services. So many women told us, "I didn't know this could happen. My doctor didn't explain what happened. I don't know who to turn to for support." Evidence-based childbirth education is a critical element in closing these information gaps, improving outcomes, and supporting new families. But sadly, fewer parents are attending childbirth classes, and childbirth education isn't currently covered by public or private insurance for the most part. Eleni Segas from the Preeclampsia Foundation created this slide to show the complex factors that surround a woman and her family before and after a severe maternal event. There we go. And while better clinical care has been the primary focus of these California toolkits and the national safety bundles, which you may hear about later, everyone, including the patients, wants optimal care. But there is more to the story than did she or didn't she leave the hospital alive. Women need to have their prologue listened to. What were their dreams? What were their expectations? What did they know before they got to that event? What are the provider's experiences in providing care to her? And then afterward, women need to be listened to be informed about what to expect postpartum after they're discharged home, to understand what happened and why. And it may take several conversations that providers just aren't able to provide. They need emotional, informational, and practical support, and it needs to be in language and terminology they can understand and delivered in a supportive and caring manner. And they need to know when to connect and contact their healthcare providers for what symptoms after hospital discharge, and they need reassurance, most of all, that it's okay to feel overwhelmed and seek mental health support. And when they don't get this full story, women and their families suffer greatly. Melissa Price had a massive hemorrhage 8 days after the birth of her twin boys. Despite nearly dying and experiencing 2 major surgeries in 10 days, there was no follow-up care when she was discharged home. Weeks later, she recognized the signs of post-traumatic stress herself and sought out mental health care to help process her near-death experience while she was caring for her 3 young children at home. And she was left alone to manage all of that. My elderly mother, in contrast, had 6 weeks of home visits by 3 different caregivers every day after her heart surgery in Cleveland, Ohio. And I don't begrudge my mom these services, but I don't understand why new mothers who nearly die in childbirth aren't given the same. Melissa volunteered on the California Hemorrhage Task Force, and we learned a lot from her about what women and their families need. California has included patient perspectives and their needs, as well as clinical best practices in all of our maternity toolkits as a result. It's one thing to work to recognize and respond in a timely and appropriate manner to obstetric emergencies, and I applaud the work being done in my state and across the country to educate and train hospital staff and physicians on better management of preventable causes of maternal death. Another important goal, though, is to support evidence-based practices so that complications are prevented in the first place. Childbirth education can play a critical role in partnership with maternity clinicians to meet the information and support needs of new mothers. The Maternal Deaths Act and the Maternal Health Accountability Act are investments in our nation's health because every mother counts. Thank you so much.
Good afternoon. My name is Shauna Cox. I'm the Associate Director for Science for the Division of Reproductive Health. And so today I wanted to start my presentation with the estimate that is often cited that about 700 women die of pregnancy-related complications every year. But I think it's important for us to understand, and other panelists have shown, that these are just not numbers. These are women that we loved, women that we cared about, and who contributed precious gifts to our lives and that need to be remembered. This number also represents the irrefutable disparities that Black and white women experience in this country. Black mothers are 4 times more likely to die as a result of giving birth. And we know that these numbers are going up. Is it because of increasing maternal age? Is it because of increasing chronic conditions? What is the role of the current opioid epidemic? Are we just doing a better job of finding the cases? We need to understand why. So CDC is committed to preventing pregnancy-related deaths and ensuring the best care and outcomes for all mothers. CDC works to support national surveillance of pregnancy-related deaths to understand trends and patterns. In addition, through a partnership with CDC Foundation, Merck for Mothers, and the Association for Maternal and Child Health Programs, CDC has embarked on a critical project to support states and jurisdictions to extensively review the circumstances surrounding each and every one of these deaths. By leveraging the findings of these maternal mortality review committees, we can find ways to prevent pregnancy-related deaths. CDC will continue to support states and their committees. To date, we have over 48 jurisdictions and almost 30 in-person training in using maternal mortality review committees. With better standardization and understanding of the data, we can identify interventions that will have the most impact and implement quality care in the right places for the women that need them. A recent report from this partnership released this past February found that almost 60% of pregnancy-related deaths are preventable. We see here on this slide that mental health and substance abuse are common contributors to these deaths. We see that the causes of these deaths are multifactorial, with an average of 4 contributing factors for each. As I noted earlier, there are troubling disparities in pregnancy-related deaths, and there are also differences in the leading causes of death by race. So, for example, while 12% of maternal deaths among non-Hispanic Blacks are due to preeclampsia and related conditions, it is only 5% among white women. Of note, a Black woman is more likely to die of a pregnancy-related death when she is highly educated with multiple degrees than a white woman with less than a high school education. But there are still gaps in this data. Only about a quarter of the deaths in this 9-state report had a solid recommendation for prevention. So we have to keep the foot on the accelerator in support of these state maternal mortality review committees to get the most accurate counts, the most accurate causes of deaths, and recommendations to prevent future deaths. When moms and babies deliver with care teams best suited for their needs, and we rigorously implement quality care initiatives that have been shown to reduce complications, they can also reduce disparities. States need support in developing fully functional review committees for them to put data to action. And so we must all work together to have collective impact to reduce these tragedies nationally. Thank you.
My name is Michael Liu. I am the former director of the Maternal and Child Health Bureau, currently a senior associate dean at George Washington University. Before I get started, let me just take a moment to give a shout out to Maddie for your leadership, your dedication, all that you do to make sure that no other family has to go through what you and Tatia and your family have gone through. And to turn your personal tragedy into a national movement to really do something to save mothers' lives all across the country. So I just want to, if you could all just join me in thanking you for her leadership. Let me also just start by saying that I believe in 21st century America, in the most powerful nation on earth, no woman, looks like it's advancing, that no woman should ever die from pregnancy and childbirth. And yet, as you've heard, more than 700 women die each year. More than 50,000 women suffer a life-threatening complication. Maternal mortality has more than doubled over the last 30 years, while large disparities, racial, ethnic, socioeconomic, and geographic, have persisted. For example, an African American woman today is still 3 to 4 times more likely to die from pregnancy and childbirth as a white woman. It's a gap that we haven't been able to close in decades. So what's driving such high rates of maternal mortality in this country? Well, there are many different factors that play a role, but I think one of the most important driver of maternal mortality is women's health going into pregnancy. Today, many American women are going into pregnancy with chronic conditions like hypertension, diabetes, and heart disease. Sorry, it's just advancing on its own, which certainly increase their risk for pregnancy complications. We also know that about half of women are going to pregnancy either overweight or obese, and we know that obesity is a major risk factor for some of the leading causes of maternal mortality, such as hemorrhage, preeclampsia, and thromboembolism. And that's why I truly believe that a key strategy for eradicating maternal mortality in the United States has to be to improve women's health, not only during pregnancy, but before pregnancy, between pregnancy, and really across their life course. But what I really want to talk to you about today is to focus on improving quality and safety of maternal care in the United States, because I really think that this is the low-hanging fruit. And that's because that most of us believe that at least half of all maternal deaths and morbidities in the United States are preventable by improving the quality and safety of maternity care. For example, we know that many of such complications are the result of either delayed recognition or misdiagnosis. So I can still remember back my first week of OBGYN residency, I saw this woman that was brought in by an ambulance in eclamptic seizure. And when I reviewed her chart, she actually had a prenatal visit that morning with elevated blood pressure, and nothing was done about it. It was just completely missed. She was sent home. On her way home, driving on the freeway, she had a seizure, which almost killed her, and that was completely preventable. And we also know that some of these deaths and complications are the result of delayed response or just mismanagement. I've certainly seen cases of obstetrical hemorrhage where the entire scene was just chaotic. Right? The attendants like yelling at everybody and throwing instruments around and losing sponges, and everyone's kind of flailing. In the meantime, the woman just keeps bleeding out. So much so that she uses up all her platelets and clotting factors, so she couldn't clot anymore. And so she ended up losing so much blood that you have to transfuse her 10, 20 or more units of blood. But I've also seen cases of obstetrical hemorrhage where the entire team is just calm and poised, and everyone know what they're supposed to be doing, and someone's designated to keep track of time and instruments, and someone's designated to just run back and forth between labor and delivery and the blood bank to keep up with transfusion, and the attending just kind of running the entire team as if they were conducting a symphony. And you can prevent so much blood loss. You can prevent so much morbidity if you know what you're doing. Now, of course, it's hard to do that if the first time that you're doing that is when it's actually happening, right? And this is where protocols matter. This is where drills and simulations matter. And that's where these safety bundles come in. Okay? So safety bundles are bundles of best practices, protocols, simulations, drills, toolkits, and other resources designed to improve the quality and safety of maternity care. They're really designed to improve the 4 R's, right? Readiness, recognition, response, and reporting. And reporting is really important, right? Because you need to know what worked, what didn't work, and how can we improve next time so that you can keep on learning and keep on improving. So 9 such bundles have been developed to address some of the most common causes of maternal mortality, and more are in the works. And we know these bundles work, and I actually saw these bundles work firsthand In California, it's the network that Dr. Morton talked about. That it was kind of with a network of really dedicated doctors, nurses, midwives, health educators, public health professionals. We went around the state, knocking on door, going hospital to hospital. We did grand rounds for OBGYNs. We did in-service for labor and delivery staff. We engaged hospital CEOs in changing practice and changing policy. We helped them run quality improvement drills. And then we watched the needle move in real time. So Dr. Morton showed this slide already. But if you look closely here, up until about 2006, California was trending with the rest of the United States. Right? The maternal mortality just kept going up. Right? Between 2006 and 2012, California's maternal mortality ratio went from a high of 16.9 to a low of 6.2. That's a 64% reduction in maternal mortality in just 6 years. And think about all the lives that were saved. African American maternal mortality also decreased by roughly 50% in the same time period. So when I became the director of the Maternal and Child Health Bureau back in 2012, wanting to put the M back in MCHB and wanting to share the successes that we have in California with the other states so that they don't have to keep reinventing the wheel, that's why we launched AIM, Alliance for Innovation in Maternal Health. Here I really want to just give a shout out to Jean Mahoney and her team at ACOG, the American College of Obstetricians and Gynecologists, that over the last few years they've engaged more than 25 national partners and have enrolled 18 states and more than 800 hospitals, with 8 more states waiting in the wing to really try, with the idea of getting these safety bundles into every single birthing hospital in the United States over the next few years. And that's why I really want to urge you to support these 2 bills, because not only do these bills support the vital work of the state maternal mortality review committees, which are so critically important, they will continue to support this national movement to really finally do something about maternal mortality, to increase the quality and safety in maternity care for all women. And if we can replicate the success in California across the nation, we can cut maternal mortality in half over the next 5 years. And that's about halfway to zero maternal mortality in our generation, which I truly believe that is achievable and must be achieved for the most powerful nation on earth. Thank you very much. No, I think there's a model that we use a lot in public health, and it talks about if you want to bring about real social change, you need 3 things, right? You need the knowledge base, you need social strategies, and you need political will. And I think over the last couple decades, we're getting better at the knowledge base. And I think that's where data and science becomes so important, understanding what's really going on and what can we do about it. And that's the social strategies part. And again, my kudos to CMQCC and all the work that was pioneered by California, and now it's spreading like wildfire across all the different states. And the states are really doing a lot of really innovative things to really try to improve quality and safety and try to save mothers' lives. So we got that knowledge base going on. We got the social strategy going on. The big question is, do we have the political will to get it done? Like, do we have the political will to get it done? We haven't had this much political will for a very long time. I remember hearing about these issues when I was a medical student almost like 30 years ago. But finally, we got this national momentum that's that's building up, that's happening. The question to all of us here who care so deeply about this issue is, do we have enough political will this time to get it done?
And I would second Michael's comments. I mean, CDC has been doing pregnancy-related mortality since 1985, where we've been getting data voluntarily from states, linking data from the death certificate to the birth certificate. And that data is very good, and like I mentioned, in regards to national surveillance to understand what the trends are, what the patterns are, what the disparities are, what the leading causes are. And maternal mortality review committees are not new either. They've been around since the 1950s, but unfortunately, a lot of times they're based on volunteers. And so when a volunteer retires or moves on to a new position, that review committee then is no longer sustainable. As Michael mentioned, really having the political will and developing that infrastructure at the state level to have these review committees and be able to extensively review the causes behind each of these deaths. Not only the medical and clinical causes, but also the social causes and what are the entire circumstance of this woman's death and how can it be prevented. And then that information can feed back into some of the work that Christine and others are doing in California in regards to the perinatal quality collaboratives and implementing these safety bundles, understanding where the leading causes of death are, and then bringing it back to clinical care and understanding where there are opportunities to prevent future deaths from happening in the future.
I'm not Jenny Joseph. I'm for stand-in for the day. My name is Claudia Booker. I am a certified professional midwife, home birth midwife in Washington, D.C., born and raised Washingtonian. Another factor that I think we have to always look at are the broader issues of what's happening in hospitals and hospital management. We have hospitals that are closing, not just here, but rural hospitals where women are hours away from getting maternal care. We have hospitals that do not have the facilities anymore to have anesthesiologists around 24 hours a day within 15 miles of the hospital. We have hospitals who do not have the staff or the expertise to allow women to have a trial of labor after a previous C-section. We live in a city now where there are no maternal hospitals, no hospitals that offer maternal care east of the river. And the impact that has, that now we have another burden of having no hospitals where our mortality hotspots are. I've been on the Infant Mortality Review Committee for the District of Columbia for over 11 years. I see this every month from the viewpoint of the other side of the mommy-baby dyad. I see the baby diet part and what things we could do to change that. And we now have a city where families have to go find care, where care is no longer brought to the family. And that barrier is a huge barrier. The closing of hospitals, the inability of communities to get to the hospitals, the elimination of different forms of Medicaid in the city. These things are going to really impact even further on the systems that we're trying to establish, those decisions. And we're back to political will. We're back to deciding that these things are important. When you look at not just the mortality, but the morbidity, thank God we almost lost one, that are happening. That's very frightening because the impact upon a pregnant person of almost dying in childbirth shakes her view on herself and her position in the world and her position in her family. And if she were not already suffering from the life stresses that women of colors suffer from, almost dying really shakes your mortality and your ability to have any resilience. And so we have to look at the other issues that are going around. How are we funding our hospitals? When we close a hospital, what do we have in place? Why aren't we looking at more easy access clinics around the District of Columbia? Why aren't we looking at inviting other allied health professionals to join our team? Why are we not making it, this is so revolutionary thought, I am Capitol Hill. Why aren't we requiring every hospital that is licensed in the District of Columbia to take every insurance and every form of public insurance so that when I'm laying in the ambulance saying where I want to go because they take my form of insurance, they don't say no Can you imagine being in labor and getting an ambulance and not knowing where you're going to end up? And when you end up there, there's nobody who looks like you, and there's nobody who speaks your language, and your family doesn't know where you are, and you walk in and there's nobody you've ever seen before, and you want to have a normal physiological vaginal birth, you're scared to death. You're scared to death. And those feelings of disempowerment get embedded into your birth experience and into how you relate to your child. And we are having children born who, because of the trauma that their mothers and their families went through, in the healing process that their mother has to go, that there are periods when the children literally feel like motherless children, like they're a motherless child because there's so much trauma that their parents have to heal from, and dispowerment. And we have to keep that in mind because we are a nation of people who heal each other. We do that. We're healers. And so we have to really invest in not breaking each other.
Christine, did you want to add anything? Okay, I did. I do. Just in line with what everybody has said, and specifically Claudia. To me, I'm also a doula, so I, help moms in birth, deal with midwives, and obviously, the midwifery model of care far exceeds what you can get in the hospital. Although I must say, ACOG is moving towards the midwifery model of care in a lot of hospitals, which just blows my mind. I'm so happy. However, what I see all the time, and this speaks directly to the disparities and directly actually to these two bills, because if there was uniform death certificates in all 50 states and there was a box on the death certificate, every death certificate, that said whether or not the woman was pregnant at the time of death, then that would be recorded as a maternal mortality statistic. In 2001 in California, that box wasn't there. So my daughter, even though I was there and I saw what happened, was not recorded as a maternal mortality statistic. These bills would systemize that so the death certificates would all have that, and then do the investigations. And during the investigations, of course, the ethnic background of the mom that died would come out, and the medical reasons would come out. But for me, a lot of it, most of it, has to do with cultural competency, the lack of cultural competency training, the respect that women of color are not given in the hospital as opposed to white women. And it runs the whole gamut from, some idea that non-white women can stand more pain than white women can. So white women need the drugs, and African American women, Mexican women, whoever, they don't need any drugs because, they can deal with the pain. And that kind of stuff, like Claudia was saying, speaks to really horrendous outcomes in birth. You may go home with a baby, everybody may be intact, either initially or ultimately, but the whole experience is imprinted in your brain. Literally, I believe it's imprinted in the baby's brain too, because of the trauma that they suffer coming down the canal due to whatever. So basically, I guess what I'm saying is the basic racist foundation of the medical institution in the United States significantly impacts maternal mortality, infant mortality, definitely impacts the morbidity that we have, and these two bills, I honestly believe, will help decrease all of that to a really large level.
Yeah, so I think what you're seeing there is a percentage issue where even though Black women are more likely to die, overall the absolute numbers are going to be more white women dying. And so that's kind of what's skewing the top leading causes of death. But as noting in your report, there are definitely different reasons and variation in the leading reasons by race. And so that speaks towards whether it's chronic conditions, whether it's an issue of what are the causes that might begin in the preconception care, before pregnancy period versus the postpartum period, and kind of that trajectory of care and how does that differ by race. And that might be some of the possible causes that's causing the leading causes of death to be different by race. But definitely wherever you're going to see, because by absolute numbers are going to be larger number of white women, they're going to kind of drive the leading causes of death. But that's why it's so important to disaggregate our data by race to be able to understand where there are differences and be able to understand that we're making sure that we're getting women to the right care at the right time in the right place, and understanding, do we need to do things a little bit differently based on the population that we're serving. So hopefully that information, if you have more additional questions, please feel free to reach out, because we'll be able to kind of help you understand that information a little bit better.
Okay, well, this concludes our briefing, and in closing, I just want to thank you all for coming today. The briefing was literally put together in the name and spirit and memory of all the women and babies who have died in childbirth and for pregnancy-related reasons. And so I implore you to go back to your bosses and your colleagues and your families and encourage them to read these bills, pass these bills, make sure they go into action, because these are the leaders and the policymakers, obviously, of the country, and they can do that, and they can save many, many, many lives. So thank you all for coming.